Thank you, sir. All back up and running now. We're going to look at the example of a woman who contracted hepatitis C as part of her leukemia treatment. And this is the relevant statement here. So if we look at paragraph 2, we can see the description of how this woman was infected. 22nd of May 1990, as a result of receiving numerous blood transfusions and blood products while she was in hospital with leukemia. I received several transfusions between September 1989 and June 1990 after I had a bone marrow transplant. And she explains that she was only 20 months old when she was diagnosed with leukemia and 2.5 when she was infected with hepatitis C. Now, she was diagnosed in 1995 with hepatitis C as part of a look-back exercise. And Sally, if we can just go to paragraph 6 on the next page, please. She says this, that about the timing of the diagnosis with hepatitis C, just after I had got my big 5-year clear from leukemia. I had gone into remission, was still having checkups, had been given the all clear when only a few months later we got the letter about hepatitis. And so that is a key theme in relation to this cohort of patients, overcoming one significant medical condition and then being faced with having to deal with a second condition. Malignant hematology is another area where individuals received blood transfusions. And we've got a statement in relation to a woman who was diagnosed with Hodgkin's lymphoma in the late 1980s, early 1990s. No need to put this up, but for the transcript, WITN 0938001. And this woman was about 21 years old when she started chemotherapy. And in 1991, she underwent a bone marrow harvest at the Valinda Hospital in Cardiff, and she received a platelet transfusion as part of that. In August 1998, so the treatment's in 1991, August 1998, she received a letter to say that the blood that had been used as part of her treatment was positive with hepatitis C. And she describes this in her statement. She felt as though, quote, she had been handed another death sentence and that she was, quote, ashamed that she was ill again. One document in relation to this witness that I want to show you, WITN 0938003, please. Now, we can see that this is a letter dated 10th of July 1997, and if we scroll down, this is a letter from a consultant haematologist, and it sets out the history that we've just been looking at, so a platelet transfusion in 1991. And then this is said, I'm not sure how often you are reviewing this lady and whether you wish to undertake the necessary testing and counselling yourself, or if you would like me to see the person. I would be most grateful if you could advise me accordingly. If you undertake the testing yourself, it is important that the sample is sent to the University Hospital of Wales for PCR testing, and it would assist administrative purposes if the enclosed form was used and some details about the sample, how it should be taken. Now, the witness says that she wasn't ever aware that her blood sample would be sent to the University Hospital of Wales, and she came across this for the first time when looking at her medical records. So the next group of patients affected by blood transfusions are those with haemophilia. Now, prior to the advent of factor 8, factor 9 blood products, some haemophiliacs were treated with blood transfusions as an early part of their treatment. However, due to the rather prolific use of those blood products, it's often very difficult to pinpoint the source of any infection in relation to the cause of a blood-borne infection. but it's right to acknowledge, and we do so in the presentation, that there are many haemophiliacs who also received blood transfusions. The next group of patients are those who suffer from sickle cell anemia. Now, this is an inherited blood condition where red blood cells are sickle-shaped, and that means that less oxygen is transported around the body. Sickle cell carriage is found in approximately 1 out of 9 people of African or Caribbean origin, and the sickle cell gene is found in southern Europe, in India and the Middle East. So you will know, but just to refer everyone and to refresh people's memories, the inquiry has produced an expert report on blood disorders, and a lot more information about sickle cell and other conditions can be found. The reference for the transcript, EXPG 602. Now, the inquiry has only received limited evidence in relation to individuals who were infected following transfusions as part of sickle cell anemia treatment. And the inquiry continues to welcome and encourage those patients to come forward and give statements to us. It's absolutely not too late for those people to give witness statements. One example that we have received is from an affected daughter, and she describes that her mother came to London in the late 1950s from St Lucia, and her mother was diagnosed with sickle cell in around the late 1980s and received 3 to 4 transfusions per year. Now, in 2013, her mother was sadly diagnosed with hepatitis B, and she died very shortly after that diagnosis, and liver disease is mentioned on the death certificate. Now, this witness believes that racism has played a part in the treatment of people with sickle cell, and we're just going to look at how she describes that. WITN 4729001, please. And if we can turn, please, to paragraph 48 of this statement right at the end, Sally. Paragraph 48, she says this: people who suffer with sickle cell disease tend to be of African heritage, and I believe that we have been sidelined by the NHS and made to feel as though we are not important. The way the disease was dealt with by the health profession was, I believe, racist, and it was not treated in the same way as other life-limiting health conditions are. The fact that sufferers were also given infected blood is another thing on top of this, and checks should have been made to ensure the blood was safe. Now, we've also received a statement from a mother of a child with sickle cell, and she describes, in her view, that there was a stigma within the health profession about treating sickle cell, and we'll look at her words. WITN 1823001. Now, this is a statement that we're going to come back to later because it's a fairly remarkable one, but I just want to look at paragraph 42, please, Sully, which is page 11, which addresses this mother's view of a stigma, and she's talking here about treatment in the early 2000s. In general, I believe that there was a stigma around having sickle cell in the medical profession at the time of my daughter's illness, which may have caused doctors to believe everything wrong with her was due to her sickle cell. When she was at King's College Hospital awaiting a transplant, I felt that doctors kept referring to her sickle cell as the reason why she was deteriorating or why she couldn't have a transplant. They said things like, oh well, she's a sickler, when showed signs of worsening, as if that explained her whole illness. So another condition that falls squarely within the inquiry's remit is that of thalassemia. Now, thalassemia, as you know, Sarah, is an inherited blood condition that causes the body to produce less haemoglobin, which in turn causes anemia and a range of other problems. And as with sickle cell disease, we have not received a lot of statements from individuals with thalassemia, and we would again encourage people to get in touch with us. It's absolutely not too late for those statements. I'm going to give an example of a statement we have received, and this is WITN 005 4001. 055 4001. So this is an individual who suffers from beta thalassemia major. We can see that in paragraph 2. And she describes that that diagnosis came when she was just 6 months old. And over the page, we can see, top of page 2 of this statement, that she required transfusions every 6 weeks. But the current position is now she needs them every 2 to 3 weeks. And this is a woman who was infected with hepatitis C. Now, because of the number of transfusions that she's had over the course of her life at a range of hospitals, she's unable to pinpoint both the relevant transfusion that infected her, but also where that took place. Simply impossible for her to know. She thinks that she was told in 1991 about her hepatitis C and thinks that this happened on a face-to-face basis, although she accepts that it could have been earlier because she has a vague recollection of family suggestions. One theme that's apparent from this witness statement, Sarah, is that she states that the hepatitis C and her subsequent liver problems have adversely impacted on her medical treatment for thalassemia. So again, we're seeing the interconnection of two different conditions. The next group of patients relate to those individuals who have been infected by family members, either via spouse or via a child. There are, unfortunately, several examples of spouse-to-spouse infections arising from a transfusion, but also examples of infection passing between parents and their children. A frequently expressed fear of women who receive blood transfusions as part of maternity care is a question of whether their baby has been infected or their subsequent children have been infected. And sadly, there are a number of examples where children have been infected by their mothers, so maternal child transmission. Going to bring up a rather unusual example, Sir, that could fall within this category, but it also could fall outside of it. This is the unusual example of a married couple who both underwent transfusions on the same day in the same hospital without each other knowing. So for the transcript, this is WITN 0286001, WITN 0287001. We don't have to bring them up. Now, the woman received a transfusion due to a postpartum hemorrhage. So this was in 1986 at the Dryburn Hospital in Durham. And she describes an allergic reaction that she experienced post-transfusion. There's some discussion whether it was a penicillin reaction to a component. But while she was in labour, her husband was admitted for emergency surgery due to a burst stomach ulcer. And he underwent a transfusion at the same hospital. Now, perhaps unsurprisingly, she was surprised when post-operatively she woke to see her husband being wheeled into the room in a wheelchair. But then what happened was a slightly different course. She began to experience hepatitis-like symptoms soon after her transfusion, and in the late 1980s she had all of the classic signs of hepatitis. Her husband didn't develop any symptoms until 2004. Now, within the family, they attributed her symptoms to being a mother and being exhausted. The transfusion happened with the third birth of their child. But it wasn't until in 2004 she looked at her husband and realised that his eyes were very yellow. He booked a GP appointment and was diagnosed with hepatitis C. It was then recommended that she should undergo testing, and she herself was also positive. So it's unclear, sir, whether this is a spouse-to-spouse infection or whether this is an example of one of them receiving infected blood or both of them receiving infected blood on the same day at the same hospital. The wife received a skip-in payment on the basis of her transfusion, but because her husband self-cleared the virus, he wasn't entitled to any payment. So I'm going to move on away from those categories to look at the different types of infections that witnesses and their family members have received. The most common type of infection from a transfusion is a hepatitis infection, predominantly hepatitis C, but there are lots of examples of hepatitis B and also examples of hepatitis A and hepatitis E infections. So you will recall the oral evidence of Peter Buckland, whose son Mark contracted VCJD from a blood transfusion in September 1997. So the inquiry has also received that evidence in relation to VCJD. HIV infections were less common, but unfortunately the evidence received suggests that they absolutely did occur. And there are also examples of people that were co-infected with more than one virus. Going to look at some examples of HIV infection. The first example is a man with leukemia who underwent a bone marrow transplant at the Hammersmith Hospital in 1982, and he received platelets as part of that treatment. His health deteriorated, and he contracted mumps and was admitted to hospital in June 1983. His wife went to visit him in hospital and then came home to receive a phone call telling her that he had died. His wife was told throughout his deterioration that the reason for his death and his ill health had been due to graft versus host syndrome because he did not have leukemia when he died. So this is 1982, 1983. Then what happens is that in 1992, she received a letter from the Hammersmith Hospital. We're going to look at that letter, WITN 0407002, please. The letter is from a professor of leukemia biology at the hospital, and it says this: "You may be a little surprised to hear from the Hammersmith Hospital after the passage of some considerable number of years. Nevertheless, an aspect of your husband's management has recently been drawn to my attention, and I would be very grateful if you could make contact with me." So the woman attended a meeting with this clinician, and she was told that, in fact, her husband had received blood infected with HIV and that the cause of his death was not graft versus host, but was HIV. She also found out, this is 1992, that back in March 1987, there had been a published account of her husband's death as part of a research paper. I'm going to look at that document. WITN 0407003. So at this meeting, she also received a copy of this medical report that was about her husband. And if we look on the top right-hand corner, this is a publication in the European Journal of Hematology in 1987, and the clinicians are listed in the middle of the page. If you look on the right-hand column at the bottom of the page, Sally, we can see that it explains the premise here. It says in 1985, 3 patients who had developed AIDS between 2 and 5 years after BMT, that's bone marrow transplant, were reported from France. In each case, the marrow donor was identified as a source of infection. Following this report, we investigated a group of patients considered to have been at risk of exposure to HIV for serological evidence of anti-HIV. The group consisted of 28 patients, 25 transplanted since January 1984, and 3 transplanted earlier who had developed late infectious complications. We report the details of one patient found to be seropositive for anti-HIV and the events preceding his death 6 months after the bone marrow transplant. Now, it's not a brilliant copy, sir, but you can see the relevant case history set out. If we turn to the final page, please, Sully, 188 internally. Sorry, penultimate page, 188. We can see at the bottom of the left-hand column, it says this: transmission of HIV after a bone marrow transplant should be preventable if appropriate steps are taken. We recommend screening not only of blood product donors, but also of the bone marrow donor recipient and any other person asked to donate various aspects. So the conclusion of this study that this woman received in 1992 was that transmission of HIV in these circumstances should be preventable if appropriate steps are taken.
At the time of the transfusion, that was 1982, was it?
It was, sorry, sir, 1982, yeah.
So there wouldn't have been at the time any test for HIV or HTLV3?
Not at the date of the original transfusion, no.
So when the article here talks about being preventable, it's looking at the position as is at the time of the article?
1987, yes, sir.
Thank you.
So, as part of the inquiry's consideration of relevant documents, we have seen a lot of documents that relate to the Eileen Trust. Now, this information is not strictly falling into the experiences of infected and affected people that have contacted the inquiry. Of course, there's some overlap. But what we wanted to do as part of this presentation is just draw out some examples of the documentation that we have seen in relation to the Eileen Trust. Now, these documents haven't yet been disclosed, and they will be in due course. I'm going to give a series of examples, but for reasons of confidentiality and anonymity, some of them are fairly vague in their detail, but it will give you an idea of examples of HIV infections for families and individuals that haven't directly contacted the inquiry. The conditions that we can see in the Eileen Trust documentation relate to a broad range of conditions, so gastrointestinal bleeding, replacement of a mitral valve, injury sustained in a road traffic collision, acute myoblastic leukemia, inflammatory bowel disease, during labour, a total hip replacement, extensive burns, and an ectopic pregnancy. So again, a similar range of conditions that we have received directly from witnesses. They also cover a range in terms of the temporal period, and some of the examples I'm going to draw out relate to the latter period in relation to the 1990s. The first example is a man who received about 22 units of blood for a heart procedure in 1983 in a London hospital. And the donors of 10 of those units were traced and found to be HIV negative, but 12 units originating from Hither Green could not be traced because the documents had been destroyed in a fire. That man sadly died of AIDS in the 1990s. The second example is a woman who was admitted to hospital in Wales in 1983 following a road traffic accident, and she received multiple blood transfusions as part of her treatment. One of the 11 donors was found to have subsequently tested positive for HIV. Now, the woman developed AIDS, and at the time of the document in question, her prognosis was noted to be poor, but we don't have any more detail about what happened to her. A third example is one of a late example of infection. So a woman who had leukemia, who underwent chemotherapy in 1996. She was transfused with 112 units of platelets and diagnosed with HIV a year later in 1997. A look-back exercise was undertaken and the infected donation was collected and transfused in August 1996. Another example is a woman who sadly died of AIDS in October 1986, and she received a transfusion in February 1982 for a postpartum hemorrhage at a maternity hospital in the north of England. Her child was born a few years later, and he sadly was also infected and died in 1985. The father of that child was also infected with HIV, and it's not clear from the documents we have about his health status. The fifth example is that of a woman who was transfused in a hospital in the Midlands during treatment for an ectopic pregnancy in 1983. The donation that she received was then found to be positive for HIV, and the donor had died of HIV. The woman died in the late 1980s of HIV, aged just 34, leaving behind 3 children. And a last example is a woman who was admitted to hospital in the northwest of England in 1996 due to colitis. She underwent a total colectomy and received 8 units of blood and 4 units of FFP, frozen fresh plasma. A look-back investigation in 1997 for another patient, so not the patient we're considering, demonstrated that one of those units of FFP was positive for HIV. So they connected the case back to her by that form of investigation.
If you just go back in your notes to the 1996 case, diagnosed 1997, but you told me about a moment ago, where you described how the unit which had been transfused was shown to have been infected. It was the unit that was tested, was it? Do we know?
So I'll check that specifically in the break. I think it probably was, but I'll go back to the documents and check that.
The reason I ask is it might follow that if the tests have been sufficiently accurate or applied, that might or should have been detected at the time. But if it's the donor, then it might have happened in a window period.
So I'll check that in the break and see if we can give any more clarification. Unfortunately, some of these documents are not terribly detailed because they're drawn from applications that people have made to the Eileen Trust, and then what investigations the treating clinicians have done around the side. So it's not always possible to be that exact, but I'll check for you and see if we can find any more information.
Sure.
So at this point in the presentation is probably a convenient moment for a break. I'm just going to move to the second half of the presentation.
Yes, well, we'll take a break until 11:45. But just before we break, can I just say one thing? Earlier in your presentation, you mentioned the relative shortage of statements that we have from those who have suffered from sickle cell or suffer from sickle cell, and those who suffer from thalassemia. You've also given some disturbing evidence of stigma that might exist or is felt to exist from those who suffer from those conditions about the way in which they have been dealt with. Can I just say that we are open to receive any statement from anyone who wishes to tell us, but they don't have to, obviously, but if they wish to tell us, we will very happily receive statements from those who have sickle cell and thalassemia, who have or think they may have suffered from the conditions which we are centrally investigating. It has always troubled me that the numbers of those who have suffered infection ought, on an impressionistic view of the overall landscape, to be much higher than the numbers that are reflected in the statements that have come forward. So it may be that there is a reluctance, for fully understandable reasons, to tell us, but we are, and I want to repeat, we are open to receive any such statements and hope that those who are listening, if they have been uncertain about it, but feel that they might want to make a statement, will do so if they can. They may help our investigations if they do. But that's all that I wanted to say. 11:45.